Hello, everyone. This is Dr. Mikky recording a lecture on Chapter 4, which is about the pharmacokinetics. And the pharmacokinetics covers the four processes. And the next slide um, provides the learning outcomes for this lecture. And then the third one defines the pharmacokinetics as the study of drug movement throughout the body. So we will know how the body deals with this medication or this drug to understand and predict the actions and side effects or adverse effects of the medications, understand the obstacles that the drug faces or encounters to reach target cells. Um, the barrier for many drugs is crossing many membranes until they get to the last destination or target organ. In general, root drugs, they will be broken down by stomach acids and digestive enzymes. The organs will attempt to excrete the medications, and most of the most important organ that is responsible for the excretion of the drugs and medications is the kidneys. For metabolism, the liver. Um, so the phagocytes also may attempt to remove medicines as being seen or considered as foreign bodies. So the four processes that are involved or included within the pharmacokinetics includes the absorption, distribution, metabolism, and excretion. These are the four processes of pharmacokinetics. So the why to apply pharmacokinetics to therapeutics or pharmacotherapeutics. The application of pharmacokinetics to the pharmacotherapeutics, in which that the pharmacokinetics of drugs allow nurses to better understand and predict the actions and adverse effects of medicines in their patients. So barriers the drug must cross before interacting with the target cell. The meds or medication administration being administered orally, pure route will travel through the body. So we'll get to the stomach, to the portal vein, to the liver, systemic circulation, to the target tissue or organ, and then target cell. So, and then it may enter the nucleus in some cases. So this is like the route or trajectory of the drug when it travels. That's the PO. That's the oral route or the PO, tablet or capsule or liquid form. So when the drug is taken orally. So while attempting to pass through the various membranes, drugs are subjected to many or numerous physiological processes. For example, we have the enteral medicines, for example. The enteral medicines in which that being the stomach acid and digestive enzymes, they will break down the drug molecules. The liver enzymes may chemically change the drug molecule to a different form. The phagocytes may recognize the drugs as a foreign body and will be removed or remove it from the body, or the immune response may be triggered. So three ways for the drug to cross the cell membrane: channels or pores, or transport system, like the pH, like a protein, or direct penetration of the membrane. So either the drug will go through the channels or pores, get some assistance with the transport system, like the pH is like a protein, or direct entry or penetration of the membrane. So the how drugs cross plasma membranes. First one is called simple diffusion, or other textbooks the label it as passive transport. The IV drugs, for example, will move from an area of higher concentration, which is in the blood, to an area of lower concentration in the tissues. So the diffusion assumes that the chemical is able to freely cross the membrane, which is a lipid-rich membrane. That's the type of membrane that's the liquid form, or I mean, the drug is going, or as a chemical is going to freely cross that plasma membrane, which is considered to be a lipid-rich membrane. Now, what are the characteristics of drug molecules that can easily reach the target cells by this mechanism, which is a simple diffusion? So the characteristic of the drug to freely cross the plasma membrane by the simple diffusion, the three main ones are small size. The drug has to be small size molecule, non-ionized, and lipid soluble, lipophilic. That's the term for lipid soluble. So it has to be small sized molecule, non-ionized, and lipid soluble molecule, or what is called the lipophilic. The open channels, an example would be that the very small molecules enter through open channels in the plasma membrane. And we have examples such as urea, alcohol, water. These organs or molecules will be very small molecules that will be freely and easily entering through open channels in the plasma membrane. The second mechanism for transport is called facilitated diffusion. So within this facilitated, or by this mechanism or way of movement of the molecules, the large molecules, ionized drugs, and the water-soluble agents are able and can um, move across the membrane by this mechanism or facilitated diffusion. There should be a use of carrier or transport, like protein, to cross the membrane. And this process does not require any energy expenditure from the cells. The active transport does. So the facilitated diffusion does not require any energy expenditure. It requires that certain proteins be present on cell membrane. However, in the active transport of the cells or organs, or I mean, the drugs are going to move through or enter the cell with the active transport or via this mechanism, then these are the chemicals of the drugs. They will move against the concentration or electrochemical gradient. So the drugs that move from lower concentration to a higher concentration against this or their gradient, they require cell energy expenditure. So they need the cellular energy expenditure and carrier protein, or what's called pumps. The pump is able to, with the assistance of the pump, it will allow for these molecules to cross the membrane by what is called the active transport. So the contrast or contra sport involves the movement, the word COTRANSPORT, contrast sport. It will involve the movement of two or more chemicals to cross the membrane. And that's the exact mechanism how the cells or molecules are transporting or being moved with this active transport by a term called contrast sport. Absorption, which is the movement of the drug from its site of administration Either it's the GI, the muscle, the skin, or subcutaneous tissue, across body membranes to circulating fluids, like the bloodstream. The primary pharmacokinetic factor determining length of time for drug to produce the effect. So the factors that would affect the drug absorption are listed here in terms of like drug formulation, the dose, the of administration, the size of the drug molecule. Uh, so before we get into the different factors that affect drug absorption, the most common routes of administration are the enteral and parenteral. The rate of absorption determines the onset of the effect. So the rate of drug absorption, it determines the onset of the effect. In other words, the onset means when the drug is going to begin working or will elicit the effect. However, the amount of the absorption determines the intensity of the effect. How strong is the effect? So again, we have two different concepts here. The first one is that the rate of absorption, slow or fast, determines the onset of the effect, when the effect will start or the response will start. The second concept is that the amount of absorption determines the intensity of the effect. How strong, how intense is the effect or the drug response? So the route of the administration affect both rate and amount of absorption. The route of administration, it's either it's PO, oral medication, IV, enteral, parenteral, and so forth. So the primary pharmacokinetic factor determining length of time for a drug to produce effect. So the absorption is the primary pharmacokinetic factor, which determines the length of time for a drug to produce the effect. So if you go back to the previous slide, talk about the degree of ionizing or ionization of drug, the degree of ionization of the drug. And for example, on the stomach acid, which is, we know that, the stomach, that's acidic, the aspirin, non-ionized and easily absorbed by bloodstream. In the small intestine, it's alkaline. The aspirin ionized and less likely to be absorbed in the small intestine. So factors affecting drug absorption, we said the route of administration. The route by which the medication is administered will significantly affect the pattern of drug absorption. The onset, when the drug begins working or starts the effect, the onset of the effect determined by the rate of administration. However, the intensity of the effect determined by the amount of the drug being administered. So which has faster onset, via intravenous or inhalation or PO route? The faster is definitely going to be the IV, because the IV is going to bypass the absorption entirely, and it will go right into the drug will be administered right into the bloodstream. Factors affecting drug absorption, rate of dissolution. Tablets and capsules must dissolve before being absorbed, so there will be a slow onset time. Drug concentration and dose. 50% of the drug absorbed, like for example, diltiazem 100 milligrams versus 200 milligrams. GI tract environment. Most drug absorption occurs and takes place in the small intestine, and small intestine has long surface area with absorptive microvilli. Now the drugs will spend less time in the stomach, so the stomach has a thick mucus layer that will discourage absorption and prevent absorption in the stomach. Digestive motility may slow or speed the drug absorption. The fatty foods in the stomach will slow drug absorption. This is one of the very important concepts as we discuss absorption, is that the fatty foods in the stomach, they will slow the drug absorption. And the food in the stomach will decrease nausea and vomiting, but it will slow drug absorption at the same time. Blood flow to the absorption site. Heart failure or CHF, congestive heart failure or shock, it will decrease the amount of blood flow to certain tissues, which in turn or eventually is going to decrease drug absorption from IM sites or GI tract. Drugs may be given to purposefully slow the absorption. Sometimes we give the drug to slow down and that's intended purposefully. We want to slow the absorption. Like an example of this one would be given the epinephrine, which is a vasoconstrictor, constrict blood vessels, with, at the same time, we mix it with local anesthetics, like lidocaine, for example. Local anesthesia like lidocaine, you mix it with epinephrine. So, well, what's the reason of adding epinephrine is to create a vasoconstriction in the area. So that will prolong the effect of the local anesthesia. Lidocaine, instead of working for only 15 minutes, can last for even like 30 or 45 minutes if it's mixed with epinephrine, because epinephrine is going to constrict blood vessels and decrease absorption. So that's one of the examples of that some drugs can be given to purposefully slow the absorption. The drug ionization. Ionized molecules, they will carry either a positive or a negative charge. Like for example, in aspirin, ASA, which is acetylsalicylic acid, like aspirin. It's an acid which will give up the hydrogen ion in the base or alkaline environment. So when ionized, which is negatively charged, it will bind with the bicarb. HCO3. So the aspirin, acetylsalicylic acid, ASA, an acid in stomach, which is acidic, remains non-ionized and then will be absorbed across the membranes that separate the stomach from the blood. So the two main concepts here is that the acids are absorbed in acids because they are non-ionized, and the bases or alkaline are absorbed in base or alkaline environment because they are non-ionized as well. And these two figures explain the previous concept. The drug interaction, oral, for example, oral or PO tetracycline's absorption is delayed if taken with food or drugs containing calcium or iron or magnesium. So the absorption of this tetracycline will be delayed if it's given with these type of food, or food containing like calcium, iron, or magnesium. Surface area, faster absorption, drugs being absorbed in small intestine and lungs. And here we have a question that I would like you to explore and find an answer for that one. Why the oral medication is usually absorbed from the small intestine rather than from the stomach. And I believe I tapped on this maybe in the previous slide or one of the previous slides that I indicated or talk about this concept, and would like you to go back and find out the answer, um, why the oral medications are usually absorbed from the small intestine rather than from the stomach. Other concepts or factors that will affect the drug absorption. Briefly, we'll go over the lipid solubility and the last one, which is the pH partitioning. The pH partitioning, the drug accumulates on the side of the membrane in which or where the pH most favors its ionization. So the acidic drugs will accumulate on the basic or alkaline side, and the basic drugs or alkaline drugs will accumulate on the acidic side. Characteristics of commonly used routes of administration. Routes of administration of commonly used medications will fall into two major groups, enteral and non-parenteral. Enteral, which is oral and or parenteral. Parenteral, which is the intramuscular or sub-Q or intravenous, IM, sub-Q, or IV. That's the parenteral. So under the enteral, we have oral or parenteral. Under parenteral, you have IM, sub-Q, or IV. And then the second group or second type is non-parenteral. Non-parenteral, which is it's neither oral or parenteral. So it will be either like topical, ophthalmic like eye, um, otic, which is ear, inhaled, inhalation, like MDIs, metered dose inhalation, MDI, rectal, vaginal, transdermal. All these types of drug administration or routes of administration of drug belong to what is called the non-parenteral classification. So the lipid soluble, what you can get from this figure is that the lipid soluble compounds can also pass directly through the cells of the capillary wall. So the pharmaceutical preparations for oral administration, it's either tablet or enteric-coated preparations or sustained release preparations. The enteric-coated preparations, they are the meds or medications, the oral meds that are released in the for patients so that it will protect either to protect the drug and to protect the stomach. So the enteric-coated preparations either for drug protection or stomach protection. Sustained release preparations, these are the capsules like filled with tiny spheres or granules or sprinkles, and it permits the reduction in the number of daily doses. Sustained release, instead of taking like 2 or 3, the drug taking it twice or 3 times a day, we can just take one sustained release and it works for 12 or 24 hours. So because that will be released steadily throughout the day, one tablet will be given orally, but at the same time that the drug is going to be released steadily over or throughout the day. Now, what is drug stability? So the drug stability that is defined as the capacity of the drug substance or drug product to remain within the established specifications to maintain its identity, strength, quality, and purity throughout the retest or expiration dating period. So the drug stability, again, it's the capacity of the drug substance or drug product to remain within its established specifications to maintain its four things: identity, to maintain its strength, maintain its quality, maintain its purity. Until it's being expired. This table it's like comparison table compares between the oral IM, sub-Q, and IV in terms of what are the barriers to absorption and the pattern of the absorption. And you can, as you see on IV, there are no barriers to absorption for the IV with the medication given intravenous. Advantage, disadvantage, comparing the oral and IM and sub-Q. And this slide shows or present or tracking the movement of drug following the GI absorption. The grapefruit juice and drug interactions. The grapefruit juice may not be safe for people who take certain medications. So we have chemicals, most likely flavonoids, and these are the chemicals that are being used in grape juice and grapefruit juice. They will lower the activity of specific enzymes in the intestinal tract that normally break down the medications. So there are certain chemicals in the grapefruit juice. They will lower the activity of specific enzymes in the intestinal tract that normally break down the medications, and that will allow, or this allows, a larger amount of medication to reach the bloodstream, and that will result in increased drug activity. Significant activity with the drug will result from taking the drug with the grapefruit juice. So there are certain medications that are not required, or it's not recommended that you take the drug with this grapefruit juice, so we can prevent the grapefruit juice effect. Because taking the drug with the grapefruit juice, that will result in that a larger amount of the drug or medication to reach the bloodstream, and that will result in significant increase in drug activity, and in some cases that will result in toxicity. So the drugs that may be affected by the grapefruit juice include midazolam, Versed, cyclosporin, antihyperlipidemics like statins. I will cover this in the cardiovascular chapters. Calcium channel blockers, anti-hypertensive drug like nifedipine, specific or certain antibiotics like erythromycin, uh, antifungals like ketoconazole, nizoral. So the grapefruit juice should be consumed at least 2 hours before or 5 hours after taking the medication that may interact with the drug. And that's again the rationale for this is that there are chemicals in certain fruits like grapefruit. These chemicals most likely these are called or the chemicals are the flavonoids, and these are the chemicals that are responsible for all this activity in terms of that it will increase the uh, the intensity of the drug when it's taken with that drug. So so some drinks that are flavored with fruit juice could contain grapefruit juice as well. So we have to check the ingredient label to make sure that there is the absence of this and that on the label. So because again, with some drinks that are flavored with fruit juice could contain grapefruit juice, even if the grapefruit is not part of the name of the drink. So that's why you have to check the ingredient label. So next slide, distribution of medications, which is a movement or transport drug throughout the body to its site of action by bodily fluid. So drugs and other chemicals compete for plasma protein binding sites. Drug-drug and drug-food interactions may occur when one drug displaces another from plasma proteins. So binding to the protein means affinity. So some have greater affinity, so the displaced drug can reach high levels, and that will produce adverse effects, and in some cases will be toxic. So albumin is the most prevalent protein in plasma and the most important of proteins to which drugs bind. So the unbound or the free drug molecules, they can leave the vascular system. Bound molecules are too large to fit through the pores in the capillary wall. So there are several types of drug-drug interactions. Um, when two drugs interact with each other, these include like addition, the action of the drug taken together as a total, synergism, the action of drugs resulting in a potentiated, like more than total effect, antagonism, drugs taken together with blocked or opposite effects, or displacement. When the drugs are taken together, one drug may shift another or displace another drug at a non-specific protein binding site. So thereby it will eventually alter the desired effect under this displacement. So when two drugs are interact with each other, that either result in addition, synergism, antagonism, or displacement. So factors influencing drug distribution, blood flow to tissues. Drugs are carried by the blood to the tissues and organs of the body. So highest blood flow in heart, liver, and kidneys. The lowest blood flow will be in the skin, bone, and adipose tissue. So what about the abscess and tumors? Low regional blood flow impacts therapy. Like when there is low blood flow or ischemia. The pockets that are filled with pus-filled pockets, they lack blood vessels or a bloodstream. So there's no internal blood vessels in these pus-filled pockets or abscess. No perfusion, no blood flow. And the solid tumors, also they have limited blood supply. So I have to keep in mind about, that these abscess, the abscess and tumors, the pus-filled pockets, they have no internal blood flow or blood vessels. The solid tumors, they have very limited blood supply. So that's will provide like implications on how to prescribe and how to administer the drug to patients with different type of abscess or tumor. Drug solubility, lipid solubility determines how quickly the drug is being absorbed, mixed with within the bloodstream, crosses the membrane, and becomes localized in the body tissues. Tissue storage. The drug may have high affinity with in certain areas or certain tissues in the body. So like, for example, the bone marrow, teeth, eyes, adipose tissue, they have high affinity and attracted to these organs or tissues. For example, thiopental, diazepam, lipid-soluble vitamins. They have a tendency to be stored in these tissues. Another example is tetracycline. It has an extremely high affinity and it will bind to calcium salts and accumulate in the bone and teeth. And that's why tetracycline is not recommended and it should be an absolute contraindication, should not be prescribed to pregnant women because that will show as a yellowish discoloration of the teeth of the when the baby grow up and has teeth. So the teeth of the baby will have some type of yellowish discoloration due to the high affinity of the tetracycline to bind to calcium salts and accumulate in the bones and teeth. Drug protein binding. Drug protein complex drugs may bind reversibly to plasma proteins, and drugs can form reversible bonds with various proteins. The plasma albumin is the most abundant and important fat protein when it for binding, to bind with drugs. Large molecule that always remains in the bloodstream. The plasma proteins or proteins in general, but the albumin, specifically albumin. And it will impact the drug distribution. So the drugs will remain trapped in the bloodstream bound to plasma proteins until they are released or displaced. So the unbound, which is the free molecules, free drug molecules, the unbound or free drug molecules that are not bound to the protein, they can reach their target tissues or be excreted by the kidneys. However, the drugs or drug molecules that are bound or what's called, they are trapped in the bloodstream because they are bound to the protein. They are not going to elicit the response or activity or effect on the tissues because they are trapped in the bloodstream. However, the unbound or free molecules, they are able to reach their target organs or tissues or sometimes excreted by the kidneys. Drug protein binding is a very important concept. Other examples like aspirin and Tagamet, sulfonamide antibiotic will displace warfarin coumadin. So these, like aspirin, Tagamet, cimetidine, or sulfonamide, which is antibiotic, these medications will displace warfarin or coumadin from the drug protein complex, or which is protein binding sites, and that will increase the blood levels of warfarin because they are going to displace the warfarin molecules. So we'll have too many of the coumadin or warfarin sodium molecules in the bloodstream, and that will increase the concentration of free warfarin. That will be, the patient will be predisposed to a high risk of bleeding and hemorrhage because of the high or increased level of warfarin in the blood due to the increased concentration of free warfarin. So the danger of administering sulfonamide to patients on Coumadin, for example, is that the explained earlier about this is that it will increase the blood levels of warfarin and patient will be at risk for hemorrhage and bleeding. Other medications would have the opposite effect, like for example, weak binding between albumin and gentamicin. So that will be the opposite effect. Blood-brain barrier and fetal placenta barrier. Special anatomic barriers that prevent many chemicals and medications from entering, make brain tumors difficult to treat. Fetal placenta barrier protects the fetus. No pregnant woman should be given medications without strong consideration of condition. So we'll have to be careful when prescribe medications to pregnant women. Blood-brain barrier. Only drugs that are lipid soluble or have a transport system can cross the blood-brain barrier to a significant degree. A neonate should be given reduced doses of medications. So the tight junctions between cells that compose the walls of capillaries and the central nervous system prevent drugs from passing between cells to exit the vascular system. So consequently, in order to reach sites of action within the brain, a drug must pass directly through cells of the capillary wall, and to do this, the drug must be lipid soluble or be able to use an existing transport system. Fetal placental barrier. Membranes of the placenta do not constitute an absolute barrier to the passage of drugs. So the movement determined in the same way as uh, other membranes. The lipid soluble or non-ionized drugs or compounds, can easily pass. So non-ionized compounds, drugs, lipid soluble, they can easily pass. The risk with drugs transfer, birth defects will result, including mental retardation, gross malformations, low birth weights. The mother's use of habitual opioids that could result in the birth of a drug-dependent baby. Metabolism of medications. It's also is known as the biotransformation. So chemically converts the drug so it can be easily removed from the body. Hence defined as the enzymatic alteration of drug structure. So the body causes a chemical change to a drug to the drug molecule. This metabolism involves complex chemical reactions. The liver is most responsible organ for the metabolism. It's the primary site. Most drugs take place in the liver. Addition of side chains known as the conjugates makes drugs more water soluble and more easily excreted by the kidneys. We have a concept called the P450 system, which is the hepatic microsomal enzyme system. It activates the drugs. It will accelerate drug excretion. Some agents known as prodrugs, they have no pharmacologic activity unless first metabolized to active form by the body. It's called prodrugs. And the problem or the risk of giving medications to individuals with liver dysfunction is that the drug will have difficulty being metabolized by the kidneys. And may result in toxicity. Enzyme induction. So a drug increases metabolic activity in the liver, changing the function of the hepatic microsomal enzymes can significantly affect drug metabolism. So the oral drugs, they enter what is called a process or a phase of the hepatic portal circulation, or another, the concept of, the term in pharmacology is called first pass effect. First pass effect, or the hepatic portal circulation entrance. So oral drugs is metabolized to an inactive form before it has an opportunity to reach the target organ. So metabolic activity may be decreased in some patients, like infants and older adults, patients with severe liver disease, patients with certain genetic disorders. So the dosage in patients with decreased metabolic activity must be reduced to prevent toxicity. So most drugs, hepatic drug metabolizing enzymes. So the metabolism of most of the medication or drugs that takes place in the liver is performed by the hepatic microsomal enzyme system, what is called or known as the P450 CYP 450 system. So the drugs either it will be considered as or act as substrates or as enzyme inhibitors or enzyme inducers. And this is one of the most important concepts in metabolism, which is to understand the P450 or CYP system. So the drugs, when they are going to act as substrates, the drugs that are metabolized by certain CYP isoenzyme, such as warfarin, naproxen, when they are given warfarin and naproxen, they are substrates of CYP2C9. I'm not requiring that you know all these abbreviations and specifics, but just to understand the concept of drugs as substrates. These are the drugs, the same, these are different drugs are being metabolized while the liver use the same CYP isoenzyme. Like warfarin and naproxen, they are substrates because both are being metabolized through the same process or the same micro isoenzyme. Drugs as enzyme inhibitors, like for example, Cipro, will inhibit specific CYP, and specifically will be CYP1A2 when it's given with naproxen, which is the substrate for that isoenzyme. So if the Cipro inhibits the naproxen, that will result in less inactivation of naproxen. In other words, that will increase naproxen blood level and prolong drug effect. So that inhibition of the metabolism had resulted in increased naproxen blood level. So that's an example of given ciprofloxacin or Cipro with naproxen, because naproxen is a substrate of Cipro, and Cipro inhibits the naproxen, so that will result in less inactivation of naproxen, which eventually going to increase or elevate the naproxen blood level and will result in prolonged drug effect. The last one, which is a drug as enzyme inducers. These are the drugs that have the ability to increase the metabolic activity in the liver, which is enzyme induction, what is called enzyme induction. So in these patients, drugs are being inactivated at a much faster rate. Higher doses may be required to achieve the optimal or optimum therapeutic effect. So again, the drugs as enzyme inducers, these are the drugs that have the ability to increase the metabolic activity in the liver, which is called enzyme inducers or enzyme induction. So in these patients, the drugs are being inactivated at a much faster rate, and higher doses may be required to achieve the optimum therapeutic effect. So metabolism doesn't always result in a smaller molecule. Therapeutic, uh, some therapeutic consequences of drug metabolism like increased renal drug excretion, drug inactivation, or increased therapeutic action. Activation of the prodrugs into active forms, or increased or decreased toxicity. And increased toxicity when inactive form of the drug are converted to active forms. An example for this one would be Tylenol, in which the metabolite is highly toxic to the liver than the original drug. The tenolol by itself is not toxic, but when it becomes, after being metabolized, these metabolites are very toxic or highly toxic to the liver. Decreased toxicity, that's when active forms of drugs are converted to inactive forms. So in every one of the 6 types or therapeutic consequences of drug metabolism, these will be covered in different chapters. So the first one was the increased renal drug excretion, drug inactivation, increased therapeutic action, activation of prodrugs into active forms, and increased toxicity or decreased toxicity. The prodrug, what is the prodrug? The prodrug is a drug when administered, it has no pharmacologic activity until it undergoes metabolism. That's the prodrug. We have a few examples of this would be like enilatro, the Visitac, antihypertensive drug. Special considerations of drug metabolism. Patient variation in metabolism, like Asian genetics, like infants do not develop a mature CYP system until 1 year of age. The elderly, the CYP system is reduced, so patient may require lower doses of the drug. Induction of drug metabolizing enzymes. Few drugs have the ability to increase metabolic activity in the liver. And an example would be like phenobarbital, which is anti-seizure, anti-epileptic drug. This drug, the phenobarbital, causes the liver to synthesize greater amount of microsomal enzymes, which will accelerate the metabolism. In other words, the inactivation of most drugs metabolized in the liver. First pass effect. If completely metabolized as carried directly to the liver via hepatic portal vein, completely become inactivated, so there is no therapeutic effect from the drug from this first pass effect. And that's why nitroglycerin is given sublingual. So it will be absorbed under the tongue, the bloodstream, goes right directly into the bloodstream. That's why it's given sublingual. Otherwise, it will be completely metabolized and go through that for first pass effect, and no therapeutic effect is given orally. Renal failure diminishes excretion of medications because the kidneys are responsible for the excretion of most of the meds. Other organs can be sites of excretion, lungs, certain glands like glandular excretion, like the sweat glands, saliva, breast milk. And the fecal and biliary system, and what is called the interhepatic recirculation. Example of medications will be excreted through this would be like digoxin, antibiotics, some antibiotics, and phenothiazines. So the interhepatic recirculation of drugs, the drugs are excreted in bile, then the bile recirculates to the liver. So this will prolong the activity of the drug. In other words, that the activity of the drug may last after discontinuation. So we stop the drug today, but still there will be some effect for a day or for a few days. So the primary site of excretion of drugs is kidneys. The free drugs, water-soluble agents from electrolytes and small molecules are easily filtered. The drug protein complexes and large substances are secreted into distal tubules of nephron, and the secretion mechanism is less active in infants and older adults. The therapeutic response of most drugs depend on their concentration in the plasma. So plasma drug levels. This is another important concept in pharmacology, which is the drug plasma level, or the drug levels in the plasma. It can be regulated to control the medication responses. So the drug doses attempt to maintain the levels in the plasma, the drug levels in the plasma to be maintained between minimum effective concentration, MEC, and the toxic concentration. So that is our therapeutic level. So when the drug has achieved plasma levels that are effective and non-toxic, that's when we say that the plasma level is within therapeutic range. The range should be between the minimum effective concentration. Below this is not good because that will not treat the patient's condition, and should be not to exceed the toxic concentration because that will become very toxic and will result in detrimental and significant harm to the organ or to the tissue. So, for example, the acetaminophen has a wide therapeutic range. However, the lithium has a very narrow therapeutic range. So the therapeutic response of most drugs depend on their concentration in the plasma. Now, the relationship between dosage and plasma levels exists for most drugs. And this relationship is linear, in contrast to the nonlinear relationship that exists, for example, for phenytoin, dilantin. So for most drugs, if the patient is taking doses that produce plasma levels that are within the therapeutic range, small deviations from that dosage produce only small deviations in plasma drug levels. So because of this relationship, with most drugs, it is relatively easy to maintain plasma levels that are safe and effective. Single dose time course. So the duration of a drug effect is determined largely by the combination of metabolism and excretion. Drug half-life, which is the time required for the amount of drug in the body to decrease by 50% after being administered. So drugs with short half-life leave the body faster. Half-life of morphine, for example, is like 3 hours. Half-life of amiodarone is 40 to 55 days. The process by which plateau drug levels are achieved. The time to plateau, which is plateau means steady level of the drug has been achieved. So we have to achieve a steady level of the drug in the plasma. That's the plateau. It takes about 4 half-lives to reach the plateau. So the decline from the plateau, 94% of the drug decrease over 4 half-lives. So digoxin overdose because it may result in overdose because it has a narrow therapeutic range. So again, the plateau, it takes about 4 half-lives to reach the plateau. So that 94% of the drug will decrease over 4 half-lives. That's the decline from the plateau. So that's why sometimes we have to give a loading dose, like give a large dose at the beginning so you can reach the plateau faster. Loading doses are important for drugs with prolonged half-life. And when it is critical to raise the drug plasma level quickly, like when you give antibiotics sometimes for severe infection, something I will give large doses at the beginning, that's a loading dose. And the peak concentration versus the trough concentrations. So these are like techniques to reduce the fluctuation in drug levels. Sometimes you will give like a loading dose, peak concentration versus trough. The reduce both the size of each dose and the dosing interval. Like rather than giving, instead of giving 60 milligrams of codeine once daily, it may be given 30 milligrams 3 times a day to reduce the wide variations in the peak and trough levels. Because the peak, which is the highest concentration of the drug level in the plasma, and the trough level is the lowest concentration measured right before the time to give the next dose. Peak, highest concentration after you give the drug. Trough level, the lowest concentration of the drug measured right before the scheduled next dose. So the key point is that the peak should not rise into toxic range, nor should the trough fall below therapeutic range or the MEC level. So the minimum effective concentration, which is the amount of drug required to produce therapeutic effect. Toxic concentration, the level of drug that will result in serious adverse effects. Therapeutic range, the plasma drug concentration between the minimum effective concentration and toxic concentration. So that's how we achieve the plateau after the 4 half-lives. We have a steady level or concentration of the drug in the blood after the 4 half-lives, or after 4 doses of the drug. All right, so that concludes our um, lecture, and we'll give more examples when we discuss the concepts in class with practice questions and case studies.